Professor Semler is a professor of pediatrics in the Department of Pediatrics at the University of Cologne in Germany. He is the head of the Center of Rare Skeletal Diseases in Childhood at the University Hospital in Cologne, and holds really many titles, both teaching and leadership within the OI community, including being chair of the Medical Advisory Board of the OI Federation of Europe, or OIFE, are an organization with whom we really enjoy working very closely. So without further ado, we will let you take it away, Professor Semler. Please hold on to your questions and think of them as we go. Feel free to jot them down in the chat, and we will get to them afterwards. Or if you'd rather unmute afterwards, we can certainly have a lively discussion as well. Thank you, Professor Semler.
Yeah, dear colleagues, thank you very much for inviting me to this session and giving me the chance to present a bit of our experience about rehabilitation and mobility in osteogenesis imperfecta. Right at the beginning, I want to say that the field of rehabilitation and mobility assessments is difficult for scientific research. Doing a placebo-controlled randomized trial in mobility or muscle training is quite difficult. Therefore, the number of good scientific publications and studies is really quite limited, and I will present some of our experiences from others, but there is not much of basic research, cell biology or things like that involved in the talk. It's more really about mobility and improving the situation of the whole patient, and not focusing on some very specific pathophysiological pathways. I have no conflict of interest regarding this talk, and especially no financial conflicts regarding any company producing any of the physical training devices. So I want to start with a bit of why are we training muscles in a skeletal disease, then how can we train and what might be specific in OI, and then a bit about vibration training and coordination training, which is from our perspective quite essential for children and adults with OI. Because I'm a pediatrician and I'm focusing on training and rehabilitation in children, but many of the topics are also relevant for adults with OI. So we can, as adults, we can learn from the experiences we have in the pediatric field. So what we know from other diseases, and since many years and decades, form follows function. Here in you see the skeleton of a patient with a hemiplegia, and you see that on the side where the muscles were not working, the bone was not growing, neither in length nor in diameter. So I think this is quite a nice example that the use and the activity of an extremity influence also the shape of the bones. This was also investigated in different mice models assessing the impact of muscle strength on bone mass. In this small study, they motivated female rats to jump a few times per day as high as possible, and then they assessed the bone mass in the tibia. And what they show is that it is important to jump, but the number of repetitions don't really influence the accumulation of bone mass. So the increase of bone mass, if they jump 5 times per day, is not that less than if they jump 40 times per day. So the bone adapts to the maximum load, even if it's just performed a few times per day. So these are two examples for what we call the muscle-bone unit, where we know that the muscles apply a force to the bone, and the osteoblasts and osteoclasts will then adapt the bone diameter, bone size, bone shape to the loads. So using your bones, using your muscles is important to have an anabolic stimulus for the bone formation. And that is something we need to keep in mind when we talk about rehabilitation, that we aim to improve bone quality or bone stability, bone mass, osteoblast function by using the muscles. And this is a system which works from not only from birth on, but already intrauterine. The children try to move, try to push, move around in the belly of the mother, and activate their muscle to strengthen and develop their bones. So this cycle of muscle and bone interaction is something we want to use, especially in OI. When we have a bone problem, we want to improve the stability of the bones by training the muscles. So when we think about what do we want to really improve with the training, with rehabilitation or physiotherapy, then we need to really think what is beneficial for the patient, what can we improve, what are the needs of the patient. And if we have defined the needs of the patient, we need to think, okay, here we have a problem here of the quality of life of the patient, and is physiotherapy the right thing with which we can improve this situation? And there we all know the International Classification of Function, which divides the whole life, the whole quality of life into different segments, and we need to be aware that personal factors, environmental factors also have quite a huge impact on the patient, on the quality of life. But those are areas which we probably cannot influence by rehabilitation or training. And then there are other areas like body function and structures which can be improved or influenced at least by training. And when we want to improve the situation, of a patient with osteogenesis imperfecta, we first need to define, is really the body function the limiting factor of the situation? Or is it maybe participation that he cannot go somewhere to do some parasport, or cannot do some activities with his peers? And then we need to focus on these things. Physiotherapy is quite important, but it will not solve all problems of a patient with OI. And therefore, we really need to think about, and I think this um, diagram of children with arthrogryposis is quite nicely demonstrating where physiotherapy can be beneficial. It can work on the level of muscles and joints and also pain reduction. It can also have an impact on mobility and self-care. Definitely, this is where the patient needs to actively participate and has to adapt his way of life to new function he learned in the physiotherapy, and this should lead to an improved participation in daily life activities. But that's something where we need to have the patient and the families supporting the training and the changes of motor function. These need to be used in daily life. It's not worth just doing training if you don't benefit in daily life from your training. And in I think we have some things which are really special, and we also have some special aims which physiotherapy needs to target during training. And that's a special field which, is not a primary job of physiotherapists, but they have to deal with this issue that we normally or very frequently have healthy parents who have not much knowledge about OI when a child with OI is born. And then these families are quite anxious how to handle their child, how to dress it, hold it, carry it. And from our experience, the first way of training and rehabilitation for children with brittle bones is that the parents learn how to carry, how to hold their children, that they will not only let the child lay down in bed, and the parents are anxious to touch their children. So teaching them how to lift a child, how to carry it around, hold it with both hands, not with some only at specific spots, but with the broad hands and with the flat hands, and support them at many parts of the body is something quite important, so that there will be some sort of bonding between parents and children. And later on, they need to be taught how to lift a child, how to lift him out of a wheelchair, not just pulling him on the arms if you want to lift him. So these are things which are not typically rehabilitation and training, but is something which improves mobility of the children. So that is something you need to be aware that at the beginning of life, teaching the parents is something important. So, but of course, there are other topics you need to target in during physiotherapy, and it's not only strengthening of muscles, it's also improving self-confidence that the children are able to do something and that these children, yeah, they, as other children, can try new movements. They don't need to be too anxious. They need to be cautious, but not anxious about moving around. You need also have the families to accept some limitations in daily life, of course, depending on the phenotype of the patient, on the severity. This will influence the limitations, but that's something families need to accept and adapt to this new lifestyle in some way. They need to have information about adequate devices. That's something physiotherapists can give. That's something for the patient organizations where they can help a lot. New parents can learn from parents with older children which devices are beneficial for the children. And it is important that the children, when they get older, that they adapt to improve capabilities. So that even a child with OI improve their motor function when they get older. And sometimes families and patients themselves believe I'm not able to sit or crawl or something like that because 2 years ago I was not able and I have brittle bones, so I will never test or try if I might be able to do something, to reach some new milestones in motor development. But that's something the children need to try, and yeah, trying something is often limited by fears, and that's something which need to be addressed in the physiotherapy. So these topics are not that specific to OI. These are more or less topics which are also relevant for children with other inborn impairments of the skeletal system or yeah, functional disability. But when thinking about what is really special in OI, then it is in one child, it's the mixture of periods where they are quite active, can walk around, can run around, and then periods with immobilization where they cannot use their mobility, where they cannot improve their muscles. So this mixture of periods of activity, muscle training, and then immobility, and then restart to learn standing or walking, then you train your muscles a bit, then you slip, then you have again a few weeks of immobilization. So this period and this change of different periods of activity is something which is really special. And as we all know, if you have trained your muscles a lot and then you are either immobilized or stop training, this will definitely influence not only your body shape, but it will also have an effect on your bones. So continuous training is something which is important, and even if one leg is has a cast, then you can continue training the other extremities. But as we all know, training and physiotherapy is also a topic which is influenced by motivation. And by now we have the middle of February, and I'm quite sure many of us 6 weeks ago had good ideas what they want to change in the new year. And I'm not sure if all these good plans are already existing, still existing. And so keeping up the motivation is quite difficult. And yeah, so of course, all families say and try to do some continuous training, but in the daily life, there are quite a number of reasons why I'm not doing my exercises today, but tomorrow. And so I think keeping up the motivation is probably a key factor for a successful rehabilitation and training. So when thinking about how can we keep the families and children motivated, I think it is really important to focus on capabilities which are relevant for the children now. It's at least we never succeeded to motivate children to do continuous physiotherapy to prevent long-term comorbidities of OI. So please train your back muscles now so that you will not develop a scoliosis in 10 years. Yeah, at least we were not successful with this way of physiotherapy, but defining reachable goals. So try to stand with holding onto the table so that you can play some specific games in a standing position instead of sitting in your wheelchair, and focusing on. So this needs to be a goal which can be reached depending on the situation of the patient at the moment. Then you can measure these goals regardless if it's how many seconds the child can stand or how far they can walk or whatever. Try to measure something so that the child has a goal to reach and then can say, oh, okay, fine, I've reached this, and then focus on something new, either new transfers, mobility of another joint to treat contractures, and also try to adapt the way of training to the patient's age, and try to include training activities into the daily life of the patients. So if you have an older child, not just going to the physiotherapy, which is not that exciting sometimes, but try to do some, send them to the gym. If you have this organized a bit, then you can definitely train the same muscles yeah, in different surroundings, and it might be more motivating for a young boy going to the gym instead of going to the physiotherapy. But what really is important and sometimes difficult is to to explain to the children and, yeah, adolescents why they should train, why they should work. Yeah, because if you are a child which is using a wheelchair, you might be able to stand, or even if you are able to walk short distances with a walker, the child might ask you, well, why really should I, yeah, try to walk with a walker, yeah, which I'm exhausted afterwards, and yeah, which is not fast. I cannot go everywhere instead of using my power chair. So really, you need to find goals and then adequate therapies which improve the daily life of the patients. Like, yeah, if you can stand or walk a few steps, then you might be able to walk into the restaurant, which you cannot access at the moment with your wheelchair or other things like that. So you need to find relevant goals for the families, and especially for the children and, yeah, adolescents. So when you have a goal which is relevant and you have a child who says, yes, I want to train and want to build up muscles and I'm really motivated to go for this, then you need to define how can I train this? And one possibility which was quite widely used in the past, or assessed in the past 10 or 15 years, is some sort of vibration training, which was yeah, applied to children with different reasons for immobility, and we have some experience with a side alternating vibration platform, which moves like a seesaw and can apply stimuli with different frequencies. And the idea of such a vibration training is that you can adapt the training, the stimulus, depending on the on the motor function the child already has, depending on the positioning of the feet. You can influence the amplitude of the stimulus, and this is quite a nice way to train muscles, and especially you can, depending on the frequency, you can adapt, you can train different motor functions. So if you have a very low frequency, then you improve the coordination a bit. If you have high frequencies, you focus on muscle force. So, but it's not only the effect on muscles you have with such a vibration training, it's also you improve the interaction of nerve and muscles. You have an increase of the circulation, and remembering the muscle bone unit, you should have also some benefit on bone mass. I'll show you in a few seconds the trials on this. They are not that convincing. But what I've said before, depending on the frequency of such a vibration stimulus, you have different ways the body react to the stimulus. And that's important because many families say, oh, the higher the frequency, the better the effect is. That's completely wrong because you need to define your goal. And if you use lower frequencies, like something around 10, 12 hertz, then you have a reaction of your body, of the muscles, which is a reaction which is um, activates agonist and antagonistic muscles. It's dominated by the central nerve system. So it's a voluntary reaction. So the body realizes that the body position is altered by the platform, and the brain activates muscles to counteract this imbalance. So it's something where the muscle coordination is improved. If you have a bit higher frequencies, then there is not enough time for the nerves to um, send the impulse to the central nerve system. So the reaction needs to be done on a spinal level, where it's a monosynaptic reflex. These are activated by frequencies in this range, 12 to 20 hertz. And in this area, the spinal cord dominates. It's some sort of a reflex-based training and increase muscle force without the need to think about or to activate your central nerve system. And finally, if you go to really high frequencies, then you have a continuous co-contraction of all the muscle that will cause an exhausted training to the muscle quite fast. After 1 minute, all the glucose is used, and you will build up lactate and really have a quite severe stimulus for the increase of muscle mass. So depending on your goal, if you want to improve coordination, or if you only want to improve the muscle mass, you need to adapt the frequencies of a vibration training. And in addition, depending on the frequency, you can reach different areas of the body. With low frequencies, you have some counteraction out to the movements also in the spine and upper parts of the body, where if you have higher frequencies, then only the lower parts of the body will react to the vibration training. So this is quite a nice theory if you are able to stand on a vibration platform. As we know, not all children with OI can use a standing device. Therefore, you can combine it with a tilting table, and with a tilting table, you of course have the possibility to increase the loading of the lower extremities, and depending on the load and the positioning, then you can activate different areas of the body by a vibration platform. So yeah, as the more the patient gets to will be verticalized, the higher the stimulus will have an effect on the muscles. And so you can improve muscle function in different body areas by verticalizing the children. So in summary, vibration training can be used to increase muscle force and coordination. It also has some positive effects regarding blood circulation, and if you have contractures in the joints, muscle activity can improve this, and it's quite useful after longer periods of immobilization after fractures or immobilization after surgeries. Regarding the effect on the bone mass, well, that's not that convincing, to be honest. There have been different reviews and small trials assessing the effect on the bone mass, and maybe due to the relatively short trial period of only a few months, no real effect have been shown on the bone mass measured by either DEXA or TQCT. One theory was also that in children with OI, the response to muscle loading, muscle activity of the bones is not that strong as in non-affected patients. So, meaning that there is some, impairments of the biomechanical responsiveness of OI bones to muscle stimuli. That might be right, but as an OI patient, I don't have any other bones. So I can only train those bones which I have, and I think that muscle training will have some effect on the bones, but the most important thing is, when thinking back again on the ICF, you need to define a relevant goal which you want to improve in the patients to have a better life for them, and you need to define, can you reach this improvement by improving body functions, or do you have to focus on other things? And that's something we tried to bring together in one rehabilitation approach, which we offer here in our rehabilitation center, where we do a lot of training, but also combining this in a multidisciplinary approach, with the main focus on improving independency and self-care of the patients. So when you want to teach a child how the child can transfer from the wheelchair to the bed, to the toilet, whatever, then it is a question of muscle force, it's a question of the device, and it's a question of technique and teaching, that the child learns where he can hold on, where to push, how he can use his arms for transfer, that he will not use the brakes of the wheelchair to hold on, and things like that. So it is also a technical training that the children need to learn how to transfer, and not only a question of the muscle force. And that's something we tried to assess in our rehabilitation program where the children stay in the hospital for a few weeks, and then we continue vibration training at home. And there we saw that with such a training for a few months, we were able to increase muscle force and walking ability and motor function measured by walking tests or gross motor function measurement. And after these 6 months, the training stopped. And then we did a follow-up and saw that in those children who learned new movement patterns, that there these stayed, and if they were able to stand and used standing in their regular daily life, these new motor functions remained. And if we were not able to change the lifestyle of the children, these capabilities disappeared after the training. So to summarize the presentation, muscle function is definitely a very important osteoanabolic stimulus for the OI bone as well, even if the OI bone might not respond as easy to muscles as it is in non-affected children. To motivate the children, you need to define reachable and important goals, which are important in the for the children and not for the doctors or the parents. So this is, from my point of view, the key factor to find training goals relevant for the children. And it's not all about muscle force, but it's improving or altering daily life and activities. So it's not of any use to train standing in physiotherapy when the child sits the other 6 days of the week in his wheelchair. Yeah, so that does not make much sense. And in the end, yeah, it is all about repetition and repetition in rehabilitation and motor function. Only by doing the training continuously and day after day, you really are able to improve your coordination and muscle function. And so that's the point, how to motivate the children to continue their training. And with this, I want to thank you for your attention and happy to discuss your questions.